Hi, and welcome to the Boundless Brain, the podcast coming to you from the WVU Rockefeller Neuroscience Institute. I'm Hoppy Kercheval. I'm joined by Dr. Ann Murray from the Department of Neurology. We're going to learn more about movement disorders, specifically essential tremors, Parkinson's, and dystonia. So, Doctor, welcome. Good to see you.
Yeah, thanks for having me. So excited to talk about this.
Good. I'm glad you're here, and I want to get a patient's go at this from a patient's perspective, because I think a lot of people watching this either are wondering whether they have these issues, they already have these issues, family members, those kinds of things. So let's help these folks out. But let me start with this. Give me an overview and a brief definition of essential tremors, dystonia, and Parkinson's, so we can differentiate among those three.
Perfect. So obviously, I like to think of movement disorders. If I know that's kind of what is that, right? I often describe it most simplistically as movement disorders are an umbrella term of when we can't move when we want to, or we're moving when we don't want to. So I often describe it as the on-off switch of movement is broken. And so then we'll divide that out into things like Parkinson's, tremor, and dystonia. So Parkinson's disease, although it can cause things like tremor and stiffness of your muscles, is actually really defined by the lack of movement. I can't move when I want to. And oftentimes when patients are affected by Parkinson's or they're concerned about Parkinson's, some of the descriptions of symptoms will be, well, you know what? My handwriting is just a little bit off. I can't pop up out of the chair and go down the hall like I could before. I can't, twist a bottle cap like I could before. They can't move, that explosiveness that
Even though their brain is telling them to move?
Their brain is telling their hand what to do. It's not necessarily that they can't know exactly what they want to do. It's that connection between the brain and the execution of the movement is a little disrupted based on the disease itself. So Parkinson's is defined by the lack of movement, not just tremor. And so one of the common misnomers about Parkinson's is that you have to have tremor to have Parkinson's. It's not true. Although Parkinson's can cause tremor, it is really defined by that on switch issue. I can't go on when I want to. Now we're going to change gears into essential tremor. Essential tremor is a different brain disease. Similar area of the brain though. So I think that that's why it can be often confusing, or kind of those symptoms can overlap a little bit. Same part of the brain, that circuitry of the on-off switch is not working normally. And in tremor though, we're really kind of talking about we're moving when we don't want to. So we reach out to grab something and boom, there my hand goes to shake, right? Or I go to eat, I go to brush my teeth and my hand's shaking. It's moving when I don't want to. And that movement, that extra movement, is really impacting my quality of life. And then the third one that you had mentioned, dystonia, which is the third most common movement disorder, is really when our muscles are firing, again, when we don't want them to. So it's too much movement. And often what it's doing is because they're firing simultaneously, agonist and antagonist. So we would say like biceps and triceps. When they simultaneously fire, what happens is actually it twists our joint. So sometimes dystonias can be in the neck where it kind of twists our kind of head posture, and it can be really uncomfortable, and it can really limit somebody's range of motion of their head. You can get it if you've ever heard of writer's cramp. That's a version of dystonia really, and actually guitar players can get it, and artists and people that kind of really are using those muscles a lot. Sometimes those muscles can abnormally fire then, and we have lots of treatments for all three of those things. So it's important to kind of bring it up so we can know what that is and then figure out how to get it better.
Yeah, and we're going to get to the treatments. But all these are linked to the brain. This is something the brain is doing or not doing?
Excellent point. Yes. So I say all the time to my patients, 100% of these things, just about tremor, slowness of movement, dystonia, abnormal firing, these aren't a hand issue. Even if I have tremor in my hand, it's not a hand or shoulder or neck issue. It's a brain issue. It's a signaling issue from the brain. The normal signal isn't getting there, either too much kind of overfiring or underfiring. Either way, the normal signal isn't getting there. And that's exactly what's causing the symptom.
If I were a patient that had these symptoms or one of these maladies, my first question would be, why is this happening to me?
It's a great question.
Can you answer that?
It's a great question. Not simplistically. So what I mean by that is that although we know there are certain risk factors, there are certain genetic risk factors, right? So essential tremor is highly genetic, meaning that it can run in families. Oftentimes when we see patients with essential tremor, they'll say, oh yeah, great grandma had it and granddad had it and my mom had it. And lo and behold, here I have it, right? So we see that lineage. Now that helps us in taking a history, but that actually we don't know, kind of if we take one step back and say, well, what actually is the one problem that's going on in the brain that's causing it? And unfortunately, we don't know that for a lot of these
Why don't
conditions.
you know that?
Yeah.
No offense, but I mean, you're a researcher,
what are we doing?
you're a doctor.
Right.
Yeah,
what are we doing?
Why
don't we know it? I think the answer to that question is complicated. Truly, I don't think when we kind of have dug into this over and over again throughout the years, there's probably not just one thing that causes any of these things. It's a combination of factors. So we might think of somebody having a predisposition, aka that genetic risk factor, and then there probably is a component of environmental exposures. So we talk a lot about in neurologic disease now kind of exposures to things like organic solvents. So what are organic solvents? These are industrial cleaners, pesticides, kind of chemicals that we've been exposed to. And some of the challenge of that is we don't always know what we've been exposed to. And it's not to kind of demonize any of those things. It's really to say, hey, we think those kind of things can really increase the risk of neurologic disease, and maybe that's a triggering factor. And I think it's really a combination of a lot of things ultimately that's really causing it. But one of our goals, of course, is to dive deeper into that, because the more we can figure out the why, the more we can figure out how to prevent it, treat it, and kind of change the course of the disease.
More common in age, correct?
Exactly. So we think that although age is a numeric value, I often remind folks that age isn't a disease, meaning that in my learners, if they come to me and say, well, she's pretty good for 72, no, that's not really an excuse, right? Meaning that age is a numeric value, isn't a disease. Now, as we get older, we are more likely to get other diseases, right? So it's important to separate those things. So as we get older, we're more likely to have arthritis. We're more likely to have heart disease. We're more likely to have diabetes. We're more likely to have hypertension. And we're more likely to have brain disease. And a lot of that is due to kind of, different factors that happen throughout the body and kind of youth factors that can kind of get harder as we get older. But important to know that just because we're getting older doesn't mean we're guaranteed to get these things. It just means that we got to watch for them.
Doctor, clearly there are physical challenges associated with these diseases. What about just the impact on the individual and their being, their identity? Because I was watching one of the interviews with you, and you were treating one of the patients, and he said it was, he's a successful businessman, but at a meeting he was kind of embarrassed because he had these tremors. What about that part of this?
Yeah, huge. Thank you for that question, because I actually think this is such a near and dear subject matter to my heart. The reason being that unfortunately, so much of neurologic disease, especially things like tremor, because it's so noticeable, right? You don't have to actually be a neurologist to notice somebody has tremor. Oftentimes you go out to eat and you see somebody with tremor. And that cosmetic, that social component of it is so stigmatizing for patients. And part of my big initiative and why I love this question is we got to change that narrative, because the reality is so much of this stuff is treatable. It might not be curable yet, although we're hopeful in the next kind of several years, we're going to have a lot of different disease-modifying therapies. But well before then, we can get that better. But in order to get that better, we have to be willing to go see somebody, right? We have to be willing to say, hey, I do have a problem, instead of just trying to hide it. And I get it, right? Because I think oftentimes people's strategy is to say, hey, well, I just put my hands in my pocket all the time. I just don't go out to eat anymore. I just limit my life, which is unacceptable to me, right? Meaning that if we're this good at treating it, you don't have to just accept it as a necessary part of your life. But you're right, a stigma around neurologic disease, especially things like tremor, especially things like Parkinson's, is so big. It's one of the big obstacles we have to overcome. But I'm hopeful with conversations like this and letting patients tell their story, just like the patients that we had. Because when they tell their story and they say, yeah, I was overwhelmed, right? There's so many misconceptions about what Parkinson's is and oh my goodness, my life is going to be over if I have it, that it limits people seeking care. And we really want to change that story.
And we will get to the treatments, but tell me a story. Obviously, you don't have to tell me a patient's name, but tell me a story that is pretty typical of the patients that come to you with that kind of description. Oh, I had a little handshake, or I was embarrassed, or I didn't think it was anything. What are the stories that you hear?
Very, very common story, right? Actually, very often, patients' family members will say, oh yeah, I noticed that, my wife or my husband had tremor even a couple of years ago, but things just happened so slowly and it was just minor. And I thought maybe he was just stressed that day, or he hadn't eaten or something like that. And then it kind of builds. So I would actually say the vast majority of people's stories there's a significant delay in diagnosis, right? So oftentimes they'll have had tremor for many years before they even seek out treatment. And I think a lot of that is awareness, right? A lot of that is kind of brushing it off, that in general, they're still living their life. So why seek out treatment if it's not really impacting me? But I think a very common story is then they interface with the healthcare system, and sometimes they get answers and sometimes they don't, right? Sometimes they get told, oh yeah, you're just getting older, kind of, that's what happens. And so again, I think part of it is really changing that story around really saying that we got to set the bar high, right? For everybody. Regardless of age, regardless of kind of background, regardless of where you're from, we want you living your best life. And if you're not, let's try to do better. And that's kind of a big piece of it. So a lot of it is messaging, a lot of it's getting in the community, and a lot of it really is to access, right? So meaning, where do we go? Who are those experts? Who do we seek out? How do we get answers? And that's one of our big things of really connecting not only here with our big movement team, which is awesome, but also how do we empower primary care doctors and kind of people across the state to better understand what Parkinson's is, better understand what essential tremor is, and know that we're here to help. And if there's anything we can do, they can always reach out.
Well, Dr. Murray, let's go there. A patient comes to you, maybe they've already been roughly diagnosed by their primary care provider, or they don't know. Where do you begin with them?
So it's all about their story. And that's kind of a common theme to me, meaning that the very first thing I tell them is that more than what anybody else has told you so far, what they've told you this is, what they told you this isn't, what they've tried, right, in the healthcare system, who you've interacted with, I care more about what your story is. Tell me from your perspective, when did symptoms start? How did it impact your life? What do you like to do in your life, right? How do you want to live your life? Because that's going to help me understand who they are. Because when we think about treatment, when we think about outcomes, when we think about the conversation around these diseases, it's not just about a medication. It's not just about an individual, let me order this thing. It's about pairing what I know about the disease to help that patient get back to living their life. And so I always start with, let me know your story, right? And part of that is really helpful if friends and family members come with them, or loved ones, right? Because I often think loved ones can kind of see a perspective of ourselves that we can't see. And I really do think that, that would be my other advice of anybody going into one of those clinic settings. Try to take somebody that knows you, so that they can weigh in too and say, oh yeah, we did notice this even 5 years ago, kind of thing. But a lot of it starts with the story itself to understand, what has been happening in that individual patient. And my best way to know that is hear straight from them what's been going on. That
feels like a very holistic approach to the treatment. What's your story and what do you want to be able to do to begin that, to help define the treatment?
Absolutely. And the only other thing I would add to this is that although we've spent a lot of time already, and what we do, of course, in healthcare and especially in movement, is talk a lot about the physical movements themselves, tremor, stiffness, slowness, those kind of things, balance problems, walking problems. Important to know that all of these diseases have a social component. All of these diseases have even an emotional component. And we really want to understand that too, right? It's not good enough. I often tell my patients, it's not good enough for me to just fix your tremor. I want to make you better, right? As a whole person, we got to explain what's going on so that you understand. We got to demystify it. We often have to kind of unlearn bad thoughts about these diseases, Parkinson's in particular, right? The first thing I tell somebody when I've given them a diagnosis of Parkinson's is that if you take nothing else from this conversation, know that we are going to get you better. That's what I want you to take. As overwhelming as it is.
Without doubt?
Without doubt.
There's no question they're going to be better.
If they walk into my appointment and they've never been treated for Parkinson's, I will make them better.
By
Absolutely.
Doing what?
By really understanding kind of how the disease is impacting their life, and then kind of customizing our treatment regimen for their life. And what I mean by that is no one size fits all with this, right? This is not kind of I'm just going to start this medicine and I'll see you in 6 months and good luck. It's actually not like that. We're going to say, hey, I'm going to start this medicine. In 1 week, you're going to message me. You're going to tell me if it's working, if it's not working, whatever kind of in between. And then we're going to pivot and kind of continue to customize that medicine for you. And so I think, again, a lot of that is holistic, absolutely, right? But I think all of healthcare should be holistic, because at the end of the day, our goal is to help the human being in front of me, not just treat a symptom. And I think movement disorders are no different than that. We got to treat the whole picture of it, because if I can tell a patient, you're going to do better, I think that mental mindset of their expectation to actually do better is a huge part of the successful outcome, right? More than any medicine I'm ever going to give them. If they understand what's going on and can feel like they can get back control of their life, that's a huge step in the right direction.
So what are you doing? And I would imagine that then the treatments vary depending on all the circumstances you talked about. But what are some of the things you're doing here at RNI that help people get better in any of these movement disorders?
Yeah. So one, again, is kind of having this team approach. So the good news is we have awesome, talented human beings here in neurology and neurosurgery and neuroradiology. We have specialists in physical therapy and occupational therapy and speech therapy. And so one of the things is really utilizing that dynamic team approach. And I think that that's really helpful, right? To kind of say, it's not just my opinion you need to hear. We want the whole team. We want kind of everybody weighing in, seeing how we can get you better. And another piece of it is really, again, we've dedicated ourselves to kind of that quality care, that customization, that patient-centered focus. And I think that that really speaks volumes. In addition, of course, we're very fortunate to have the latest technologies, right? So when we talk about us being a comprehensive center, we're truly a comprehensive center. So there's no place in the country or world, actually, that can offer more therapies than we can right here in Morgantown, West Virginia. So we have all the latest technologies. We have all the latest kind of treatments. We have lots of research things on the horizon as well. But it's really saying that not only do we have that culture of patient-centered care, that human approach, but we also pair that with the latest science, the latest technologies, the most advanced treatments. So that you can get the world-class care with somebody that you can connect with right here in your backyard.
Yeah, you're doing, as been well documented, you're doing some amazing things here. And one of the more fascinating things you're doing, because it's not just, here's a regimen of medications
Correct.
you take. You're getting into the brain.
Absolutely,
And there's some amazing videos out there of somebody with an essential tremor or they're shaking because of Parkinson's, and you're doing a brain stimulation that nearly stops the tremor. What are you doing?
Right. So although we don't necessarily have it all figured out of why somebody has that tremor, we do understand the circuitry of the brain better and better and better, right? In the last 10, 15 years, we have understood the brain better than we have in history, right? There's no more fun time to be a neuroscientist than right now. And part of that is really understanding that the brain is a system of networks. It's an electrical communication system. And what we've realized is that with technology, with electrical currents, we can kind of shift and modulate the brain's function, the brain's communication within itself. And in a setting like tremor, we really know that kind of it's this overfiring. I often describe it as static in the operator system, right? So if I have static in the operator system, that static is firing. That is the thing that's causing the tremor. And with that electrode, with that deep brain stimulation surgery, we can put electrical current right where that static is and quiet it. And although we haven't cured the disease, as we quiet the static, guess what? The tremor quiets. And so we've gotten really kind of sophisticated in our ability to both understand where that is, right? Because if we don't know where it is, it's hard to get it better. But then also how to get it better with stimulation, how to get it better safely. Really, and again, this is non-lesional, right? We're not permanently changing the brain. We're using this device to send an electrical current in there, which means it's customizable for each patient, right? It's not a one-size-fits-all again. It's treatment that's solely customized to each patient, which is really amazing, right? And we know that that's going to predict better outcomes as well. The brain is complicated. No two brains are the same. So each of these therapies, we have super technical strategies to make sure we're delivering precision medicine.
Are you telling me these are the rare success stories? Or are you telling me this is something you can do for all patients or most patients?
Most patients, actually, if they have diseases like essential tremor and Parkinson's disease. Now, with that said, I'm fully aware that brain surgery isn't for everyone, right? It's a very personal decision. It's a personal journey. But I look at my role as being the messenger of good information, accurate information, and changing how we think about it. So, for instance, one of the things I often talk about is yes, we have medications for Parkinson's, we have medications for dystonia, we have medications for tremor. Understand that every time you take a medication, it goes everywhere in your body. It doesn't just go to the problem area. With things like deep brain stimulation surgery, it is precision medicine at its finest. It goes right where the abnormal signal is. And that is a much more customized approach. So often we can actually get better clinical results with less side effects than things like medications, right? Because we're really targeting the actual problem itself. We're trying to fix that circuitry problem instead of just inundating your brain with kind of a totality of medication. With that said, medications work. It's not to kind of, trivialize the impact that medications have, but I like to think of it as a comprehensive package. The statement I always make with my patients is, listen, I'm going to have a list of tools in my toolbox. And you know what? I'm going to use whatever tool I need to make sure you continue to live your life, because that is our North Star. The North Star is that patients should choose and want and expect to live your life. That's what I want to do. It's my job to treat the disease. It's my job to help you kind of with your disease. And it's your job to live your life. And I think we got to look at that tools, that comprehensive package. And the good news, again, is we have that comprehensive package here. That's what's so fun about it, right? We can really deliver that high quality care.
How important is it for the patient to be a partner in this, okay, that says, okay, I will have the surgery, or I will do the things that you say I need to do, or I will, because I would imagine they have a role in this too.
The biggest role, right? I often tell them, remember, they're the most important person in this journey. I'm here to help them, not the other way around, right? And so they're the most important person. They guide this ship. I'm just kind of a supporting cast to tell them what I think would help them and what I think wouldn't help them, and how we can use the latest technologies to better benefit their life. One of the fascinating things about neurologic disease, and one of the biggest rewards in my career, though, is that patients affected by neurologic disease are very invested in getting better, right? Because as we can all imagine, it impacts every moment of every day. And I think when you have things like that, even something like tremor, remember, tremor and Parkinson's disease, not life-threatening. Dystonia, not life-threatening. These aren't going to decrease your life expectancy, but they impact every moment of every day. And that's impactful in quality of life. And so they're a huge part of it, the most important part. But I think that's why them understanding what's going on in their own brain and them understanding the possible solutions is absolutely my job. It's not my job just to send them a medicine or just to kind of recommend a therapy. It's for us to communicate so that they know what they want to do, how they want to approach it.
So let's say somebody is 70 years old and they have, or 60, and they have essential tremors or Parkinson's, and you're doing these things and they're seeing progress. Is that, and they're doing all the things they're supposed to do and the surgery work. Is that short term, or is that for the remainder of their life?
So we think all these treatments last forever and ever. Important to know that the disease will likely continue to get worse, right? So unfortunately, again, we don't quite yet have a cure for Parkinson's or tremor or dystonia. So we're really talking about symptomatic management, and Parkinson's, tremor, and dystonia can get worse over time, often not tomorrow or the next day, but years, right? And so one of the things that we talk a lot about is picking a therapy that can kind of change with you, and most of them can, like DBS. And so a lot of the expectation is to say, yes, this is going to work forever. We might have to change it though, right? It might not be the exact same therapy forever, but really we don't think any of these therapies stop working.
So, and you'll stay with them.
And we'll stay with them, right? Absolutely. We're here through their journey, that continuity of care. We're a big part of that. And that's one of the biggest rewards as well. So I've been here 8 years now and kind of the R&I, and we've implanted patients 8 years ago that are doing amazing. I had a gentleman that's in his late 70s now, got implanted 8 years ago for a tremor. He golfs every day and loves it, right? It's still working to this day, and he's doing great. And those are the stories that are so fun, right? Because we get to be part of that journey.
Is that why you're here?
Absolutely. I often say that, listen, programming DBS and being part of
deep brain stimulation,
being part of these patients' journeys is absolutely the most fun thing that I could ever imagine doing in medicine, because I really do, much like you said, get to partner with them. And in that partnership, we get real tangible outcomes and their quality of life. And it's just really fun and exciting to be part of.
Is there a, and you all are having breakthroughs all the time. You're making progress. You're doing world-class things. Is there something out there like, wow, when we just figure this out, that we'll be even better at these things, or is that oversimplifying a very, very complex issue?
I think there are turning points for that. I think that biomarkers or kind of better identification of individual disease will help us, right? The better we can define what is Parkinson's in the brain, the better we can define what is essential tremor, the why. Back to your original question, the why. The better we can define that, the better we're able to impact it. Prevent it, right, would be our ultimate goal. But I do think it's gradual. I think it's stepwise. And I think we're closer than we've ever been of understanding how the brain works, how we can intervene with abnormal circuitry. And the next phase is really changing the disease itself. And I think in the next 5 years, I really am hopeful, especially for diseases like Parkinson's disease, that we absolutely will have disease modifying therapy, things that actually change the disease, not just treat the symptom, change the disease. In the meantime, our goal is to treat patients so they keep living their life, so they're ready for those therapies when they're available.
Thank you, Dr. Murray. Good work.
Thank you.
Keep up the great work.
Thanks.
Thank you. And thank you for tuning in to The Boundless Brain. I'm Hoppy Kercheval.